Broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone to our webinar. My name is Tina Karam. I'm a marketing coordinator with the Orthotic Group, and I just wanted to first off thank everybody for joining us for an hour and just taking out an hour out of your day to learn with us. The webinar this evening is functional scoliosis. It's not idiopathic, it's biomechanical. And I just wanted to point out that we have practitioners from different parts of the world, which is quite exciting. I wanted to welcome our practitioners from New Zealand. It's the early afternoon in New Zealand. And then we have practitioners from Australia. Late morning, so not too early of a morning for our Australian practitioners. And then we have also practitioners from the US and Canada. A little bit later in the evening, but I'm sure you've had your dinner and your stomachs are full. So we're ready to learn and have a great webinar. So just wanted to point out a few things before we get started on the presentation. You will notice that there is a dashboard probably on the right-hand side of your computer, and this is where you're going to communicate with us. And we really do encourage that if you have any questions on your mind, any comments, anything you're curious about, this is your opportunity to ask questions, and we will be monitoring your questions as they come in. So we do encourage during the webinar, we will do our very best to address them during the presentation. So I think that's the best way to sort of not forget, and anything that comes to mind right away, just jot it in the chat box and we'll do our best to answer the questions. If we don't get to all of them during the presentation, we'll be asking them at the end, and we have a ton of content to cover. So if we go a little bit over, apologies in advance, but will be worth your while to stay right to the end if you can, of course. Also want to point out that we will be recording the webinar, so if you prefer to sit back, absorb the information, feel free. We will be posting the webinar at a later time, as well as the presentation. Just to point out about the questions, depending on the device that you're using, you either have there's a drop-down arrow where it says questions, or you can click on the question mark and that will pull up a chat box, and that's where you'll type it in, and I'll actually see all of them that come through. Another thing I want to point out about the dashboard is there is an audio, of course you're all on mute, and that's just to control any background noise, just so that there's no noise during the presentation. But if you're having problems with your audio at all, there is an option to call in. You can use your phone as a speaker as well. And the information is just under the audio section on how to dial in or call in. So because we have a lot of content to cover, I won't go through too much more. That's pretty much all that you need to know from myself. And I'll go ahead and pass the floor over to our presenter. Her name is Dr. Cherye Roche, an extensive background, amazing experience in the healthcare industry. And I'll pass the floor on to Dr. Roche. Thank you and enjoy the webinar.
Thanks, Tina. Greetings from Aotearoa, the land of the long white cloud. My name is Cherye Roche. I have an American accent because I'm from California, but I've been living and working in New Zealand for 10 years and really, really love it. And was just bragging earlier to Tina that I used to live right there in that little spot. And for those of you who don't know, this is Lake Pupuki, freshwater lake. Used to be a volcano. And then about 500 meters across here is the Hauraki Gulf, so that's the ocean. And America's out there somewhere. So I'm very blessed to be living in God's own, and invite any of you to, make sure you make the trip someday in your life. As Tina said, we have a lot to cover. As I prepared this presentation, we chose a topic, and then once I started getting into it, I realized you can't do this topic in 1 hour. So I've really taken out big chunks of it, making some assumptions about your backgrounds and what you already know. So I'm going to talk a little bit fast, and I'm going to go right through it. If Tina sees questions that she thinks are appropriate to interrupt me for, she'll interrupt me, and we'll ask questions as we go along, which I encourage. So there's our title. What I want to point out here is that I'm going to focus on why orthotics are important in managing scoliosis and why scoliosis is not idiopathic. And so we'll talk about that in a little bit of detail. I'm going to do a very brief introduction of myself. I run around in the world professionally as the gait doctor, and I've been using a gait scan and TOG orthotics since 2004. So 15 years of using these systems and this product has given me a great deal of success with my patients and made practice, quite frankly, a lot more fun. This is this big long thing about all the things I've done in my life professionally. I really don't want to go through this and bore you with it. You can look me up on LinkedIn or on Facebook or on my websites or whatever. If you want to find out about where I am, just appreciate that I'm a chiropractor and that I've got a bunch of experience in sports medicine and biomechanics, done a fair bit of teaching at various places around the world. And also what's not on here is that I am a subject of Her Majesty in the United Kingdom, in New Zealand, and I am a US citizen as well, but the only passport I use is my New Zealand one. Right, so again, I've been with TOG since 2004. I did some work with them in Ireland, the UK, and Scandinavia between 2004 and 2009. That was buckets of fun. And then I've been doing the same thing here in New Zealand since 2009. To give you a sense of how I work with the orthotics, I have a practice with 6 other practitioners of various disciplines, and I do about 60 pairs, 30 pairs a month. What's interesting about those numbers is that a lot of those are additional second pairs. I encourage you all to go look at a webinar that I did last year sometime about whether or not you should give your patient 1 pair or 2 pair of orthotics. The answer about 70% of the time is that the patient needs more than 1 pair. And so about half of my patients get 2 pair. And quite frankly, if you look long enough into the future, probably more like 70 or 80% get more than 1 pair eventually. That's additional pairs ordered then. So I got my numbers wrong. Anyway, so lots of second orders with patients when I see them because they need them. So scoliosis. I could spend an hour just talking about scoliosis and how to understand it, but you guys all did this in school, right? So you understand that this is a curvature in the spine, that sometimes it's caused by disease or damage to the brain, cerebral palsy, muscular dystrophy, those sorts of things. But for the most part, scoliosis, the cause is unknown. So it's either idiopathic, congenital, or neuromuscular. And what's interesting is that medicine says it's idiopathic, and my response to that is no, it just means that medicine hasn't figured out yet what causes it. And I think that the biomechanists in the world see very easily what causes scoliosis that is not related to one of those diseases. So if 65 to 85% of the scoliosis we see is idiopathic, then it's a big deal, and there's something we can do about these things. There is some interesting work being done around the genetics around this, and that 62% of the people who have scoliosis, when they look at this in terms of genetic factors, they don't find them. So 38% is due to genetic factors, 62% is due to environment. So we're going to define what environment means. We're talking about the biomechanical environment. And I'm going to talk about what I think is the underlying cause for the need for orthotics to help this environmental problem for the body. And of course, there's degenerative scoliosis, which happens later in life, but it's not a function of age. Otherwise, everybody at a certain age would get scoliosis. It's more about, again, underlying biomechanical weaknesses that drive the body to be out of balance and then creates collapse and contracture in the spine. Now, this is interesting. The evidence that chiropractic manipulation, dietary supplements, or exercises, physiotherapy, can prevent this condition from worsening is weak. The evidence is weak. What's interesting is the medical people say, however, exercise is still recommended due to its other health benefits. I think you'll find that the chiropractors and the osteopaths and some of the other practitioners will tell you that some of the things they do are also have other health benefits. But there isn't really any evidence to say that we're making a big dent in the scoliosis problem simply with manual therapy. So that's kind of the background of it. There would be something to be said for looking at how to examine someone for scoliosis and looking for things like Adam's sign and all of that. We're not going to go into that. I'm going to presume you know how to identify a patient with scoliosis. I'm going to assume you know what a Cobb angle is. I'm going to assume you know how to look at an X-ray and say, yes, that's a spine that has scoliosis, rather than spending time on that. I do want to spend a couple of minutes on treatment. So this is the medical solution to this problem. I chose not to show you the gross pictures of a spine like that all opened up. But you know, Harrington rods and other sorts of steel implants that basically bend the spine back into place and then secure it there with the hardware is one option. The other option is bracing systems like the one on the right. And you know, those things are obviously potentially life-threatening and also extraordinarily uncomfortable, and oftentimes don't get the kind of results you would expect. So enough about that. That's how medicine does it. We're going to talk about doing this a little bit different. So what type of patients is this presentation related to? So we're not talking about the patient with a 40-degree Cobb angle. We're talking about the patient with a Cobb angle under 15, probably. Definitely has scoliosis, but this is not going to compromise their organ function or make them look horrifically deformed. These are the patients who are coming to see us who have recurring low back pain, acute on chronic or chronic low back pain, chronic mid back pain, chronic thoracocervical pain, chronic headaches. I've now had 14 patients whose presenting complaint was chronic headaches. We put orthotics underneath their feet, and because now every time they take a step, their head doesn't tilt one way, their headaches go away. Very fun to do. So these are the kinds of patients that present. So my basic premise is that if you bring the body into balance, it will heal itself. So treating the underlying causes. So medicine is saying, oh, there's a crooked spine. Let's treat the crooked spine. And I'm saying, well, look, there's a crooked spine. Why is it crooked? The most important word that anybody can take into a healthcare experience is the word why. Why is this a problem? And oftentimes it's about leg length. So that's where again, we could talk about lots of different things, but we're going to talk about leg length, and we're going to talk about how orthotics impact that. So for those of you who are doing physical medicine, I presume you check your patient's leg length. We're going to talk briefly about how you do that in a minute. But this is something you should be checking at every visit. And quite frankly, that you should be checking with the patient prone, supine, and standing. The number of times I've been surprised by how that changes based on the patient's different position is pretty astonishing to me. So I used to talk my patients through this stuff, but now I keep my mouth shut until I see what's actually going on. So we're going to talk mostly about functional leg length discrepancy, but we're going to start with anatomical, and I'm just going to briefly go through it, and then we'll move on to functional. So I picked this study out. This was a study done several years ago, but it's still valid. Leg length discrepancy assessment, accuracy and precision of 5 clinical methods of evaluation. So basically, they just looked at 5 different ways that you can measure, and they did that against patients who had known leg length discrepancies based on X-ray of their long bones. So the conclusion was that this study has shown that the clinical methods of leg length discrepancy assessment chosen for testing are dissimilar in their accuracy and precision. So the bottom line is, it doesn't matter how accurate you think you are with a tape measure from the ASIs to the medial malleolus, or from any point to any other point, or simply doing an Alley's test. You're not going to get a good sense of the anatomical bone length without taking a long bone X-ray. And it's as simple as ordering an X-ray like any other X-ray and asking them to do a long bone study and giving you individual measurements for the individual right and left femur, the individual right and left tibia, and then you get the actual length of the bones, and then you know that what portion of what you're looking at is anatomical versus functional. So if you suspect, you can suspect an anatomical leg length if, now this is clinical suspicion, if there's a previous trauma, i.e. a fracture to a long bone. That makes sense, right? If you have a positive Alley sign, so for those of you who don't know, ALLI stands for anatomical leg length inequality. So if you have an Alley sign, what that means is when the patient's lying on their back and their knees are bent, either their tibias are longer and one knee is higher than the other, or their femur is longer and one knee is more forward than the other. So also, if you're someone who does manipulations to the pelvis and spine, whether that's muscle energy, mobilization, adjustments, SOT, doesn't matter. If you do a treatment, the patient rocks up to the patient to the practice with a leg length discrepancy, and then you do something to them on the table and their leg length discrepancy resolves, great. I really challenge all of you to get your patient up in that moment and have them walk them down the hall for 1 minute, get back on the table and see if it changed, right? Because you're probably not correcting that long term. So if their leg length discrepancy resolves following treatment, but returns after you have them walk them down the hall, that's an indication of a functional problem. If their anatomical leg length inequality is present, we want you to use full sole lifts whenever possible so that the whole foot is elevated. Again, this is another full talk, but if you just give the patient a heel lift, not only are you going to lift that pelvis up a little bit on that side, but you're also going to rotate it forward. And so if you put very much of a heel lift under a patient's foot, it's only going to balance their pelvis when they're standing still. When they start walking, they're going to be thrown all off because it's not underneath the sole of the foot. If you're going to use a lift, there's no evidence around this that I can really find. It's sort of a general rule of thumb. You take whatever the anatomical difference is and you add 50% of that, and you see how the patient goes clinically. And then you can kind of push that a little bit if you want. Now, in addition to that, even if you suspect an anatomical leg length discrepancy, also do a gait scan, add custom orthotics to the care plan, because almost all anatomical leg length inequalities also have a functional component. So if the patient, for example, has a right short leg because of a true anatomical discrepancy, if they concurrently have a functionally long left leg because of how their feet are working and they're having biomechanical issues, they're giving them a left long leg, that's going to compound their leg length discrepancy. Excuse the siren in the background. My clinic is above a medical facility. But I'm just going to carry on. Otherwise, assume if you're not sure whether the patient has an anatomical or functional leg length discrepancy, and the patient doesn't have the funds, for example, to go and have the x-rays done, just assume it's functional. Treat it as functional and see how you go. Because you usually can see clinically that you're getting some correction of the leg length discrepancy. And if you just can't get that last 4, 5, 6, 8 mils, then you add a lift. Now, I'm using this picture on purpose. If you look carefully, there's a finger right near the red line. That's my finger, and my finger is underneath the medial malleolus of this patient. When you measure at the medial malleolus, the difference is 25 millimeters. If you do the same measurement at the patient's heels, now it's 35 millimeters. So the soft tissues in the heel, how they're oriented, how thick the fat pad is, there's a bunch of variables in here that will lie to you about what's going on at the heels. So when you're measuring leg length, get your hands underneath the patient's ankles, get them prone, and really find the underneath side of their malleolus, not on top of it, because you'll roll. If you go here, you'll roll off of it. It'll give you inaccurate measures. You get underneath it and get in the bottom of the bone, you really see the difference in that leg length. So now let's talk about a functional leg length. This is really the key to managing scoliosis. The number of times I've done this is astonishing to me. It's boatloads of fun because people feel dramatically better in a matter of a few weeks once you finally nut out that they've got a functional leg length, and all of the crazy things they've been doing for the last 5 years to fix their back pain are all now for naught because you just sorted out this leg length difference. So this is a patient, a 45-year-old woman. Before I do treatment, she's got a little bit of a leg length, maybe a centimeter difference. Then I do my treatment. It takes 5 minutes, and I'm going to show you what I do really briefly. And now she's got no leg length discrepancy laying on the table. Then I stand her up and I have her walk up and down the hall for 1 minute. She comes back and lays on the table, and nearly all of it is back. So if I had her walk around for a day, she'd come back and she'd be out at the leg length would be back to where it was originally. So this is really, really simple biomechanics. I just have the patient prone. So the assumption is that if she's got a left long, right short leg, that she's got a left ilium that's rotated forward and a right ilium that's relatively rotated back. So all I'm doing is using these SOT blocks. And quite frankly, again, it doesn't matter. Use adjusting, use mobilization, use SOT, use whatever you use to bring balance to the pelvis. You'll still get a very similar outcome. I put the blocks under the patient like they're on the left, and then I use very light mobilization, grade 1, grade 2 mobilization pressure on the pelvis. In that picture on the right, my right hand is on the patient's left ischial tuberosity, and my left hand is on the patient's PSIS on the right. And I'm using my arms and the orientation of my arms as the direction of the force. So it's P to A, and on her left pelvis, the pressure is a bit S to I, and on her right pelvis, the pressure is a bit I to S, inferior to superior. So it just puts a little torque back into the pelvis, bringing her back theoretically into balance. And when I did that, and then I take the blocks away, so now the blocks aren't there, the legs are back to balance. Then I put her on her back. Well, I stand her up and I put her on her back. So we'll talk about standing her up. Now, I've exaggerated this a little bit with those red lines, but if the patient has a calcaneal eversion, this is a really interesting sign to look for. If you look carefully at the Achilles tendon should be in an hourglass shape in a normally oriented foot. In this case, the medial aspect of her Achilles tendon is quite straight, and the lateral aspect is more curved. That's just an indicator that there's some rear foot valgus there, and when she's weight bearing. When she's on her back, and this is the real key to the scoliosis thing. So, this is the big take home. Getting the patient's foot into its neutral position. There's a whole talk on how to find neutral position. I do not do this like the podiatrists do. When the podiatrists take a hold of the distal end of the fourth and fifth met, and they dorsiflex the foot and then find neutral position, they're actually putting the foot in a position that it's never in a weight-bearing environment, because they're artificially putting a valgus stress into the forefoot. I know that's hard to do verbally, you have to see it, but what I'm doing is I'm actually palpating the dome of the talus, and I'm putting the dome of the talus so that it's central, that it's in its neutral position between the two malleoli, because that's where the foot's going to go when the patient is about to strike their foot on the ground. So imagine this patient is walking, and so if we look at the central picture, that's her right foot. So imagine her left foot is on the ground, she's swinging her right foot forward and it's about to strike the ground. She'll dorsiflex her foot into that position, and that's where it'll be. And she's got a forefoot varus on her right side of about 20 degrees. If you look at the other image on your reading right, that's her left foot, and her left foot has a forefoot varus angle of about 30 degrees. So she has a forefoot varus that's 30% more on her left foot than her right foot. The general rule of thumb for me is that the further distal on the foot the problem is, the further up the kinetic chain the result will be. So if the patient has a rear foot problem, but their midfoot and their forefoot are fine, they're probably going to have plantar fasciitis, maybe a little posterior tibial tendonitis, maybe a little ankle pain, but they're not going to have those big knee, hip, SIJ spinal problems. When the patient has a big difference between their forefoot on left and right, as their forefoot loaded, the left foot is going to pronate more while forefoot loaded on that left side than on the right. And that eventually is going to torque the pelvis. And I have images to show you how that works. So essentially, to simplify this, the foot bone is connected to the backbone. What happens when the foot hits the ground? Your varus foot, so we were just looking at a non-weight bearing varus foot, your varus foot then becomes valgus because of the weight bearing, and it does what you see in that image. So when the right, in this case, the right foot collapses, it ends up tilting the right hemipelvis up. Now that's counterintuitive, and most of the images that you see in books don't show that. They show it the other way. This is correct. When that pelvis tilts up, the lumbar spine curves to the left and the thoracic spine has to adapt. Again, I've got more images for that in a moment. So what does a functional leg length, or sorry, how does a functional leg length occur? You have all these events that happen throughout the kinetic chain, which we're now going to go through. So the foot hits the ground, and if you've got rear foot varus that's now going to become valgus, you get your talus rotating medially and inward as the medial longitudinal arch collapses. And so the podiatrist will look at the Feist line, and they're looking at the navicular in that case, which is going to sit about there. And they look at how the navicular changes from one position to a lower position. But again, although that's a great test, it only tells you what the foot is doing when the patient is standing with their tibia right over the top of their foot. It doesn't speak to what's happening to the foot at heel strike, through early heels pressure, through mid stance, through forefoot. It doesn't give you the whole picture. And most of the time, these problems are not about an arch collapse. It's a lot more complicated than that. So the calcaneus and the mid-tarsal joint pronate. When they do that, they cause internal tibial rotation. The internal tibial rotation causes internal femoral rotation. So you can see that image on the right. The tibia rotates in, the femur rotates in, then the pelvis rotates forward. So see the arrow with D on it. The pelvis rotates this way. Now notice that the ASIS in this rotated position is forward relative to this one, and your pubic symphysis is lower as well. The whole ilium rotates forward. Now, because of how the axis of rotation is in the sacroiliac joints, when this happens, the acetabulum actually moves downward. And when the acetabulum moves downward, it makes this leg longer. Now, imagine you're inside this sacroiliac joint. So because of this excessive rotation through the tibia and the femur, this ilium is rotated forward, creating extension stress through the sacroiliac joint, right? At the same time, you've got all this rotation and you're getting an iliac flare. And so there's separation of the ilium from the sacrum. So you've got external flare along with this extension irritating that sacroiliac joint. Now, at the same time, this is weight bearing when this is all happening. As this patient is forefoot loading and all of this is happening, their left leg, if you look over here on the left, their left leg is swinging forward. When the left leg swings forward to heel strike, the pelvis rotates this way. So you're creating even more distractive stress through that sacroiliac joint, and you end up with a lot of SIJ dysfunction. So that explains why so many of your patients have this ongoing sacroiliac dysfunction that doesn't really respond sometimes to really good conservative treatment. If you're not recognizing that the foot is causing it, you're in trouble. So that then extends into the lumbar spine, irritates the lumbar facets along with the SIJ, and you end up then having stress to the piriformis, to the iliacus, to the psoas, all of these muscles that support and stabilize the rotation. So remember, these muscles, they attach on the posterior lateral side of the femur. So when this femur rotates in, it's going to stretch all these muscles and it's going to pull this ilium down. Now, appreciate that this is all happening. You have to look at this as if it's in a suspended environment. So the foot collapses, internal, rotates the ilium down. So the ilium goes down, and that's why you've got this change here. But when you now add gravity, and now you're standing on a long leg, now this hip drops and this hip elevates when you stand on it. So now we're going to talk about pelvic shifts. So on top of all of that, when your stance on your right leg, the pelvis is going to shift to the right, putting, again, stress in the right SIJ and in the lumbosacral joints. When your stance on your left leg, when your stance on your right leg, your left pelvis should drop. So one of the things you can look for when you're watching the patient walking down a hallway, when their stance on their right leg and this drops, great. If their stance on the other leg and this doesn't drop, then this sacroiliac joint is tied up. But the point here is that it shifts, it drops, it extends, it rotates, it flares, lots of stress on your sacroiliac joints. All those stresses, torsional and tilt stresses, go up then through the thoracic spine and create the curvatures, which we'll talk about again more in a minute, and then up into the cervical spine. The number of people I've seen with cervical dysfunction that's related to their leg length discrepancy is a big number. And so you get facet irritation and muscle hypertrophy and suboccipital contracture and cervicogenic headache. And so that's where these headache patients came from that I was able to help. So let's look at a presentation. So that's just the basics of how this goes. It's easier if you see this with a patient. So here's so I've got an old man, a young man, and a middle-aged woman to show you. So this guy's a mess. He fractured his femur and his tibia when he got hit by a car from the side. So this is an AP pelvis x-ray. Couple of things I want to share with you about this. First of all, you cannot tell leg length discrepancy from an AP pelvis because of all the things that the pelvis is going to do to lie to you about where those femurs are. So if you look at this, you'll notice that if we measure the difference between the femoral head heights, right, 3.5 centimeters, right? Okay. Well, but when we look at, here's the top of the left ilium and here's the top of the right ilium, it's half that. So what's the leg length discrepancy? This is a standing x-ray. So because he's standing, what's happening in his lower extremity is impacting his pelvis and rotating and tilting his pelvis, right? If you look at the sacral ala right here, it's less than a centimeter. So what is it? You don't know. What's really interesting is, so remember, this is 3.5, which is what you would normally look at. Oh, there's another picture here. Clinically, when you lay him down, it's 2.5. So you look at that and say, okay, it's got a 2.5 centimeter anatomical leg length discrepancy. Maybe. Let's see. So previous trauma, fracture of the right femur, tibia, and fibula. Post-operative hip. Now this is his right femur and right tibia and fibula that he broke, but his hip replacement is on the left because his left hip just basically gave out from compromising on that damaged right side. So he currently has bilateral hip pain and low back pain. So these are the x-ray findings. He's got, his lumbar spine is toast. He's just got degenerative changes all the way through. The joints, the discs. He probably got this compression fracture in the accident. Nobody noticed it because it wasn't his biggest problem. And he's got postural changes that were noted on the x-rays as well. So that's the leg length clinically. There's his iliac height is 1.7. This is just to show you the degree of the changes and the spurring and the lipping, and this is just not a happy spine. There's that one again, right? So now this x-ray is taken at an x-ray facility that has a spinal bucky. So they've got an x-ray bucky that's large enough to take a spine x-ray. They just lower it down and they put it down low enough that you can see from above the femur to below the tibia. And then they've got a ruler that has lead numbering and lead markers so that you can see those on the x-ray. And then the radiologist literally just measures from that point to that point and tells you how long the bone is. So that's what that is. Now here's his old femur fracture. He no longer has the hardware, but he's got a giant callus there. Here's his tibia fracture, but he's still got the hardware in there because it was so munted. And here's his old fibular fracture, right? You can see from this that he has an anatomical leg length discrepancy in his tibia because you look at the tibial plateaus and the right one's shorter than the left one. Fair enough. And you can probably appreciate that this right femur is shorter than this left femur as well. That may be due to the addition of this prosthesis, but who knows, right? But what's interesting, with this patient, the right leg anatomical leg length insufficiency is due to the trauma and the loss of the bone length in both the tibia and the femur. However, what we'll find out in a minute, is his left foot overpronates, rear foot, midfoot, and forefoot, resulting in a left long functional leg length discrepancy. So his functional problem on his left side complicates his right short leg. There's just a close-up of the difference in those knees, right? Now, we're not going to read through this because it'll take too much time. The bottom line is when you do the measure, because this is just a read of the x-rays and what they see, but when they do the measurements of the individual bones, the anatomical leg length discrepancy is 1 centimeter. That's all. So I make the clinical judgment that he's got 1 centimeter of anatomical leg length discrepancy short right and 1.5 centimeters of functional leg length discrepancy on the left because of overpronating through his foot. So what do? Because it's 1 centimeter anatomically, I put 50% of that, 5 mils, just 5 mils. Now this is a guy who clinically had 2.5 centimeters on the table and 3.5 centimeters. If you look at an AP pelvis and look at the top of his femurs, it was 2.5 to 3.5 centimeters. I put 5 mils underneath his right foot and put him in orthotics to balance out his left foot. And he had a great outcome. A marked decrease in his hip and groin and his back pain, was able to carry on with his career as a massage therapist. He got so much help when he got injured by a massage therapist that he wanted to become a massage therapist. So I met this guy at a massage therapy training, and he did super well with orthotics. And then I think he had about 8 weeks of therapy after that. He was a patient at the chiropractic college, so he was being treated by a student there and at students at the massage school. So he did really well. but he'd been getting treatment from those people for months prior to getting his orthotics, and the orthotics made all the difference.
Dr.
All right,
Roche, we
new
have a
guy.
question. Sorry to interrupt.
Yeah,
Yeah, we
sure,
have a
no
question
worries.
that's come through from one of our practitioners. The question is, does scoliosis start off this chain of events, or does the foot produce the scoliosis in a typical presentation of functional, alley?
Yeah, in a typical presentation of a functional leg length discrepancy, my belief system is the problem starts with the foot. The foot creates an asymmetry in the pelvis then reacts to that, and you get a scoliosis. Something I didn't create a bunch of slides for, because again, it's another big talk. The take home that I tell my patients is, where does this all come from, right? Why does the patient have pronation? More so when one foot than the other. The answer is that it's because of the bony architecture of the feet. So the tarsal bones, in the case of Mark, the tarsal bones in his left foot were misshapen to the point where he had more pronation through his rear foot, midfoot, and forefoot on his left side than his right side. So it's a little bit, the analogy that I make is it's like glasses. My eyes are misshapen differently right than left because the muscles in my eyes are not the right shape and length. That's a congenital problem. So I have to wear glasses. I've been wearing glasses since I was 10 years old. And if I take my glasses off, I still can't see because the glasses don't fix my vision. The glasses correct my vision while I'm wearing them. The orthotics do the same thing. You have an underlying congenital problem that has to do with foot shape and therefore foot function, because structure dictates function. So it's the lack of structural integrity in the foot that causes the foot to overpronate, which then puts stresses in the soft tissues. Sometimes that's plantar fasciitis, and sometimes it carries all the way up the kinetic chain into the pelvis and all kinds of other things, piriformis syndrome and IT band syndrome and all of that. So the answer to the question is the foot, in my opinion, the foot comes first. The exception is when the patient has a disease or some other predisposing spinal problem like a hemivertebra, or they do have cerebral palsy or muscular dystrophy or whatever. And so there's lots of bizarre, rare neuromuscular diseases that will cause the nervous system through the brain to cause asymmetrical contracture of the muscles in the spine, which creates the scoliosis. That's the exceptionally rare. What comes into our practice is all day long is people who are neurologically basically normal, but have these mild underlying biomechanical problems in their feet, which then carry on and create these problems. So this guy is 29 years old. He's a keen footballer, but he works full time as a laborer. So he's had all kinds of challenges, mostly with his groin and back. So he's been going through medicine and had injections, and which was all the problem. And he was out of football for 6 months, and he just returned to football. And he was fine with work and football, but he has great trouble sitting. So it's not often that I see a patient whose problem is sitting, but it means that when he sits, his body gets irritated and probably swells up from being irritated while he's standing. And he noted, patients come to me all the time and say, yeah, everybody tells me I've got a leg length difference and that he's got a right short, left long leg. So this assessment bit down here, these are my abbreviations. BAPS is bilateral asymmetrical pronation syndrome, left greater than right. So now we're on the right track because he thinks he's got a left long leg. Right forefoot. Now I grade the varus in the forefoot and rear foot on a scale of 4. It's actually 0 to 3. 0 is normal, 3 is severe. So he's got mild forefoot on the right and moderate plus forefoot varus on the left. In the rear foot, it's neutral, and he's just got a little bit in the forefoot. That should be enough. So he's got a long leg. I suspect in this case, for a variety of reasons I'll show you in a minute, that he's got an anatomical short tibia, maybe a femur, but certainly has some pelvic torsion. And then I did some adjusting, and these are the abbreviations for the kind of adjusting I did in his spine. So I adjusted him as above. We ordered 2 pairs of orthotics, Run Flex for his work shoes, and Soccer Flex because he's so keen, and because the orthotics I want him in at work need to be bulky and strong and durable. And so I put him in a nice big fat Run Flex, but he can't put those in his soccer boots. And he appreciates that as soon as I put the orthotics in his hand. So we get him soccer flex orthotics for his boots, which because he's a keen soccer player, he's prepared to spend money on. And he came back 3 weeks later to get fitted. So same sort of deal. He lays on the table. This is why I suspect there's a bit of anatomical difference with him. This is before anything. So he's got 15 mils of difference in his leg length when he's prone prior to treatment. We did the alley sign. This is his femur. His left femur is a little bit long. That could be because his pelvis is torqued, right? If his pelvis is rotated forward, it'll do that as well. So I don't know. This is for his tibia. His tibia is definitely longer. So in this position, I'm pretty sure his tibia is longer on the left or shorter on the right because the pelvis isn't influencing this. So after I treat him, then he's down to 5 mils. So it didn't go to 0, it went to 5 mils. So rather than putting this guy through a bunch of radiation, I make the assumption clinically that he's got a 5 mil anatomical leg length discrepancy. And so then, of course, when he gets up and walks up and down the hallway for a minute, then he comes back and he's right back to 15. So the treatment corrected his pelvis temporarily. As soon as he stood up and walked around on an overpronating left foot, he went back to having a long left leg. So appreciate it. I always call these things a long left leg, not a short right leg. This is just to show you some of the orthotic group stuff. This guy balances pretty well. That's not bad in terms of his balance on the scanner. But here's the take home, right? So now we see in his scan that his left foot is far more dysfunctional than his right foot. And that he's kind of okay through this heel, but then he has a big pronation pretty quick and his body slows way down to try to control it. So this is going to be his shins and his hip trying to slow this down. And then he ends up on his second met and he puts this pressure on his first metatarsal. So this is what I see routinely is that people who have a 4-foot varus that are overpronating onto that get this heaviness here and nothing here, right? So that's his skin. So here's his rear foot. So he's on his left rear foot, too long and too much. He's on his right one, too long and too much, but not quite as bad. When we look at his first metatarsal on his left foot, big buildup of pressure quickly. Here it's more gradual, right? He's got no help from his arch, so he definitely needs some arch help. And his forefoot is all over the place in terms of how much pressure he's got in the different mets. Those are the numbers. So yes, he's overpronating in his rear foot relative to his midfoot, but it's relatively mild. That's not a ton, right? So I'm not that fussed about that. Where it's interesting is that he's really heavy on his second met here, and he's kind of at the heavy end on his first met here, but he's not in the red. But he's not putting his right one down enough. He's not got enough pressure on his right first met. So that then leads me to do this, and you guys won't be able to read this, but basically I got him a pair of soccer flex orthotics, and we had them posted a couple of degrees in the rear foot. I'm looking for what I did. Yep. Let's say on that one. Here we go. Rear foot. We went on the soccer flex. We went neutral. So we went the neutral soccer flex with a met pad low profile, just to keep his foot more stable when he's in his soccer boots. But then we got him a run flex, and now we're putting 2 degrees 4-foot post, 1 degree on the right, and 2 degrees on the left in the rear foot, and neutral on the right to give him that asymmetry. Now, the deal with this is that's what I chose to do with this guy. Quite frankly, most of the people that I work with the Orthotic Group are letting the lab do this, which is also a perfectly reasonable thing to do. They'll see those scans and give this patient a pair of orthotics that'll work for them. And he did really, really well. I don't have a post slide for him, but within, I think it was 2 weeks, his groin pain was gone. And within 4 weeks, his back pain was gone. And he was back to full-time soccer, full-time working, happy as Larry. And I hear from him about every 18 months or 2 years to recover his orthotics because he loves them. All right, so this is one of my favorites. This is a 15-year-old kid. This I want to tell the whole world that uses orthotics, you have to start looking at these teenagers. This kid is 15 years old. His presenting complaint is heel pain and right anterior knee pain when he's playing basketball or running. They did not complain of scoliosis. Nobody even talked about scoliosis. And he had about 2 months of chiropractic care before he saw me, and these conditions were not clearing up with adjusting and soft tissue work. So the dates are interesting because this happened so fast. So he comes in on January 30th. His mom is there with him. This is what he's got. We showed her the scoliosis, and that got her. Mom was like, wow, she realized straight away that the heel pain and the knee pain are not a big deal. The scoliosis is a big deal. So his diagnosis is he's got right greater than left plantar fasciitis, and asymmetrical pronation, right greater than left. He's got a right infrapatellar tendonitis. So it's not a patellofemoral problem, it's a tendonitis problem. And he's got a functional leg length inequality right long with a pretty significant scoliosis. So no treatment was rendered on that visit other than using those SOT blocks to demonstrate the functional leg length discrepancy. And after walking in the hallway, the leg length inequality came back, and he'd had limited improvement. So they purchased a pair of Sportflex, one pair, because the kid only needs one pair. They fit in his school shoes and his trainers and his sports shoes and everything, one pair. And he's going to outgrow them every 6 months. So you don't want to spend too much of their parents' money. And uses them in all of his shoes. And he was instructed to return for the fitting. And then we adjusted him twice a week for a couple, 3 weeks. And then once a week for another 3 weeks. So 6 weeks of treatment afterwards. And so that's what he looked like before. So pretty significant elevation of his right hip, depression of his shoulders. And then that's his balancing scan, not too bad. That's his scan. Again, that doesn't look really horrible, other than he really gets onto his big toe on his right side. And again, he collapses quickly into here and goes off on his toe this way. There's his numbers, not that fussed about his heels, right? His arch is collapsing early and maybe a bit long and a bit strongly. That's his left one. There's his right one. Again, this is the guy who you just send this to the lab with lab's discretion, and you're going to help this kid out. We're not going to go through this in detail, but that's the information the lab gets you about that. Oh, right. Oh, yeah. So we saw him on the 30th of January. 3 weeks later, he gets his orthotics, and we adjust him for a while. And so 6 weeks after that, here's his spine. All right. Massive difference in this kid's posture. Is it perfect? No. Is it 80% better? Yes. But he's in his shoes with his orthotics when he's standing there. So this was a really fun case, and so I saw his cousin and his, a bunch of other people from his family. It's a great way to get referrals, is to have success. So this is what we gave him, was a pair of Sportflex. After the treatment, he was doing well. He had no pains. He fell on his coccyx a little bit later, but he responded to that really quickly, and he was away. And so now he recently moved back to the Netherlands, but he was coming every month for wellness care and for sports enhancement. And then we updated his orthotics a couple times before he left for the Netherlands. I'll go through this really quickly because we're going to run out of time. So this is a rower, an elite rower for the Danish rowing team, with basically chronic low back pain and Osgood-Schlatter's. And he had the best medical care Denmark could offer, Denmark could offer. So, but he wasn't getting any better. So he quit rowing when he was 19, and he continued to have low back pain forever. And he was a chiropractic student. He had all the physio, chiro he could ever want. And he continued to have right knee pain and low back pain on an ongoing basis. Before we adjust him, he's got a 9 millimeter leg length discrepancy. After, he's got 1. We look at his forefoot varus, and he's got a big right forefoot varus deformity and a pretty big right rear foot deformity. So if you look at the 2 white lines, so on his left foot, this is a little bit and this is a lot. So I would call this a mild rear foot and forefoot varus deformity, and this is a moderate one. That's what his pelvis looked like. Again, we won't go through a lot of detail, but just notice that there is a difference between the different areas you can look at for what his leg length is. You cannot depend on this x-ray for leg length. So his diagnosis, I do this because this is how we did this in America. Bilateral asymmetrical pronation syndrome with forefoot and rear foot varus deformity causing torsional internal rotational stress up the lower extremity and with pelvic tilt, torsion, and rotation, resulting in chronic irritation to his SIJs and his facets. So we put him in, because he's got to see patients in a clinic, we put him in dress flex for clinic. We put him in a sport flex for the various sports he wants to do. And then we put him in a run flex just for his kick around shoes for walking around on the weekends and that sort of thing. The first week he was in his orthotics, he was worse, but that's because he wore his orthotics all day on the second day. He's like, oh my God, everything hurts. And I was like, you idiot, right? Just do it like I tell you to. So 1 hour additional each day. So he went back to proper adaptation and he had a complete resolution, all pain gone in 10 days. And he returned to sport with no pain within 2 weeks, except that then he played footy and sprained his ankle 4 weeks later. So I saw him on crutches. But anyway, he recovered from that and did really, really well. So we're going to skip through this because we don't have time. But basically, this posture thing is not static, it's dynamic. And that's why the orthotics are such an important part, because the orthotics are dynamic. We're not looking at stacking bones up. We're looking at creating better neurological function and communication between the foot and the brain, which then causes the rest of the body to be in balance. So orthotics and proprioceptive input are important to understand. There's a bit of research on this about how this is about what's called muscle tuning. I think some of the TOG lectures talk about this, so you can go back and look at some of that. But it's about how the foot gets stimulated proprioceptively. So the way and I'm going to use the S word, the way I sell orthotics to the patients is I explain this to them. If you put a rigid orthotic underneath your foot's no longer stimulated. Your foot can't move. You can't absorb shock. You can't give your brain the feedback it needs. That's why the TOG orthotics are so amazing, because they're flexible and yet they have 100% memory, and they're going to stimulate your feet. So they feed that neuromuscular system properly. It's also about how you recruit the muscles. So it turns out that it's more important how you recruit as opposed to strength. So if you want to improve performance, so with scoliosis, this is where it feeds back to this. The emphasis is often on strengthening muscles to try to create more stability in the body. What's actually true is if you get better recruitment of the muscles and they recruit in the right order, you're going to do better. So if you bring balance to the body and you take all that tilt and twist out of the pelvis and the lower extremity, you create a better neurological environment for the body to then fire the muscles in the right order so that you get better recruitment patterns. Just to take us away for scoliosis for a minute, this is an old study by a podiatrist called Rothbart, who I knew a long time ago. And so he associated these pain syndromes with postural effects and with biomechanical foot faults. So all of these things, plantar fasciitis, patellofemoral tracking syndromes, SIJ inflammation, sciatica, low back pain, thoracic outlet syndrome even, headaches even. He demonstrated a patient that had TMJ dysfunction that got better with orthotics, and scoliosis. So all these things can be addressed, as you already know. So we're almost done. So treatments to improve posture should start with altering and creating a new proprioceptive input through the orthotics, and begin with the foot, because then the muscles in the spine will do better. A quick word about footwear. So when my patients are new to my clinic, they get an email that asks them to bring 4 pair of old shoes that represent the different types of footwear that they wear. And I'm looking for certain things. So if you look at the upper left, you'll see that right here, this word is gone. And if you look really carefully, there's a circular wear pattern here. This person is doing what's called an adductory twist or a supinatory shift, where when they get forefoot loaded, their heel shifts medially, and it gives them that circular wear pattern. So their right foot is certainly worse. You can also see that in the rear foot. In this one, this is totally worn down, so the blue is there, right? And the heel is completely worn down. So this has blue underneath it. This has worn it away, and it's worn away here. The left foot is worse than the right foot. Here, the right foot is worse than the left foot. And look at all this lateral weight bearing and then all this big toe weight bearing. Then these shoes are a problem anyway for a bunch of reasons. And then also make sure you look at the upper of the patient's shoes and look at how this shoe is soaked. They're both collapsed, but the shoe is collapsed. So when you put your patient in brand new orthotics that they're paying hundreds of dollars for, don't let them wear them in these shoes. When you see that their shoes are broken down like this, don't put orthotics on top of an asymmetrical footwear environment. Not good for the patient. Wow, I did it. 5 minutes left. Okay, I'll take a breath now. Questions?
All right. See if any questions have come through. Thanks, Dr. Roche. Let's take a look here. Give it a couple of minutes. I don't see any new questions coming through.
Okay, well, I'll reiterate about the previous question.
Yeah,
so
sure.
Again, what I say to the patients is the take home is, why do I have this problem? You have this problem because your parents have this problem. So your parents or your grandparents gave you the shape of your tarsal bones, which is now dictating how your foot will move. And when your feet move asymmetrically, that creates asymmetrical rotation through your lower extremities, which then creates asymmetrical tilt in your pelvis, which then gives you a long leg on one side, short leg on the other side, creates a tilt. Then if you've got a right long leg and you're tilting up on the right hip, the spine is going to lean to the left and then correct and go back the other way and give you a left lumbar curve. You'll usually overcorrect, and then you'll have to get a right thoracic curve. And then you'll usually correct again and get a left thoracocervical curve. And every time you take a step, your head is tilting to the right. And if you look really carefully at your patients from the back, you'll oftentimes see that in the cervical spine, particularly if the patient's sitting there looking at you and their head is tilted, you'll see that one side of the neck, the muscles are hypertrophied and the other side is flat because their head's been tilting that direction all that time, and all those muscles are trying to restrict that tilting.
Okay. Thanks, Dr. Roche. I don't see any other questions. Actually, no, I do have a question that's come through. One of our practitioners is asking, are there any exercises you use as an adjunct to orthotics to attempt to mimic the effect and reduce external reliance?
So I think the question is there a way to get the patient to do exercises while they're using orthotics to get better, so that then they don't have to use the orthotics, so they're not reliant on the orthotics? That's a really, really common question from the patients. You mean I have to wear these for the rest of my life? And again, I make the glasses analogy. So again, because we're talking about the shape of the bones, the presence of the orthotics is not fixing the underlying problem. The underlying problem is creating a functional movement problem. And so when you put the orthotics underneath the feet, you balance out that asymmetrical movement. Without the if you wear the orthotics for 2 years and then you take them away, all the problems will come back again. And it really doesn't matter how much exercise, treatment, whatever you do with the patient, it's gonna come back. Now, the truth of the matter is there is a whole series of exercises and stretching routines and scoliosis specific treatment protocols to help people to stretch out the tight muscles and strengthen the weak muscles, and to bring more balance to the muscles in the spine, which if the patient is prepared to do that twice a day, every day for the rest of their life, they will be better. But nobody does that. Nobody's going to be that compliant for their entire life. And what you're doing is you're treating the patient's outcome. You're treating their symptom. You're treating the fact that they have a curvature of the spine by looking at the spine, instead of appreciating that chronic problems often don't start where the pain is. So yes, you can, if you have a scoliosis patient and you see that they have a functional leg length discrepancy and you're going to put orthotics underneath them, absolutely. A whole series of exercises to strengthen their weaknesses, stretch their contractures, get them to create more balance in their life, in their body. But what happens is they're then not reliant on the exercises, but they are reliant on the orthotics. So you can keep it with most patients, the average patient who's going to be patient with this, it's a case of do orthotics, do some yoga, do some Pilates, do your fitness. Here's a handful of simple stretching exercises. If you give the body balance, again, from the very beginning, put the body in balance, it'll heal itself. All those muscles will start to just relax where they need to and strengthen when they need to when you put the feet in the right balance. I'm going to say one more thing. This is with kids, there's an epigenetic perspective to this. So if you've got an 8-year-old who's got a functional leg length discrepancy and a scoliosis, their feet are still growing. If you change the environment that the foot is growing in, i.e. put an orthotic underneath it, the theory is, capital T theory, there's no evidence for this, this is my theory. The theory is, as the foot grows, it will now grow differently than it otherwise would have, because the stresses placed upon it are going to be different than they otherwise would have been. So I have had a couple of cases where I've been with kids long enough where they actually didn't need orthotics after years of wearing them. Put them in an 8-year-old, check them again when they're 18, sometimes they don't need them. So that's the only environment where sometimes just time and the orthotics and growth, the person might not need their orthotics.
Okay, another question has come through. How do you determine or measure the amount of forefoot and rear foot correction? So, for example, 2-degree rear foot and 1-degree forefoot.
Right. So that is something that needs to actually be taught in person, because it's about appreciating neutral position and where the rear foot and forefoot are. There's lots of ways to learn how to do that. There are forefoot measuring devices, that sort of thing. You can also look at your scan. And so as a general rule, I'm just looking at pronation and looking at it whether it's mild, moderate, severe. And so then posting based on that to a degree or 2 or 3. I'm very conservative about how much posting I put underneath the foot. I very rarely will give somebody 4 degrees of posting anywhere, because I find that the patients then start to slide off the orthotics a bit and end up with some lateral foot problems. But again, if you're uncertain, I suggest you let the lab, so send in your scans and ask the lab to make orthotics for you at lab's discretion. Let them make orthotics for you and trial them underneath the patient. If for some reason you're not happy with the outcomes, most of the time, the outcomes are going to be great. If you're unhappy with it, get on the phone with them. What do you see with this patient? Let's review the scan. Should we be more aggressive? Because the answer to how much posting you use is going to depend on the age of the patient, their presenting complaint, their musculoskeletal history. Do they have any disease? Are they diabetic? Do they have a flexible foot? Do they have a rigid foot? Do they have a short first metatarsal? Do they have a hallux valgus? Do they have a bunion? So there's lots of questions that have to be asked. And that's why in the system, the gait scan system asks you for that information. You know, they ask you for some basic, what does the foot look like information by filling out the form. And then there's that opportunity to type in the box. My encouragement is you tell the lab as much as you can about what you know about this patient. And if you don't get the results you want, then go back to the lab. And here's the kicker for this. Where people can sometimes get challenged with doing orthotic therapy as part of their practice is that it sometimes just becomes hard. It becomes, oh gosh, now I've got to get a hold of the lab and I've got to do blah, blah, blah. If you think about it and you look at your numbers in your practice, 80, 85, 90% of the time, the orthotics are going to work great. And those challenging patients are going to happen 5 or 10% of the time. But remember, you're going to learn something every time you do that. And so you're only going to have to ask that question once or twice, and then you're going to get it. So for example, when I first started doing orthotics, I had no idea what a plantar flex first ray was, or that a rigid and a flexible plantar flex first ray should be treated differently. I was still making orthotics for patients and having lots of success. It wasn't until one of my patients who had a rigid plantar flex first ray came back with a new pain in their foot that I went back to the lab and said, what's going on? And they said, well, do they have a plantar flex first ray? I said, what's that? So they told me, and I went back and I looked at it. Oh my, lo and behold, they've got a rigid plantar flex first ray. Okay, let's modify the orthotics. So the orthotic group is happy to work with you with that, particularly if you get that done in the first sort of 60 days, get that sorted out. That's plenty of time to see how the patient reacts, and then make a modification of the orthotic and get it right. And as long as that doesn't cost the patient anything, everybody's happy. I'm sure Tina will tell me if I'm talking out of turn.
No. That's great. That was an amazing presentation. Thank you, Dr. Roche. Very informative. Sure. We hope that you and that everybody has enjoyed the hour. And I don't see any other questions that have come through. But again, if you think of anything afterwards, you'll have my email address. Feel free to email me, and I'll pass on the information or the questions to Dr. Roche. We're hoping that we can have you present at another webinar in the near future. I think this was a great success. And again, like I mentioned in the beginning, we have recorded this webinar. It will be posted on TOG.com along with the presentation. So as a refresher, you can watch it at a later time or share it with some colleagues. I just wanted to mention also that we do have some additional webinars coming up to finish the year off. We have on Tuesday, this coming Tuesday, at Eastern Standard Time, 7:30 to 8:30 p.m. Eastern Standard Time, which is about, I would say, maybe 10:30 a.m. New Zealand time, maybe a little bit later, but you can change the time zone when you register. You can change a time zone to meet your own, and then it'll tell you exactly the time for your area. But check out TOG.com for some new webinars. I know we have leg length discrepancy with Dr. Ross coming up, I believe November the 21st. But just check our website under education, and you'll see all the topics there. We have October to finish off, November, and we have December as well. A really great one about prefabricated orthotics is coming up as well. So check that out. And I wanted to thank you again for joining us, and we hope to see you online soon. Have a wonderful...
Can I just add one more thing, Tina?
Yeah, absolutely.
Yeah. So based on this presentation, guys, if you, I don't know how many of you are still there, but if this was a presentation about a lot of different things, so if that did, create questions for you, and there's a topic that you'd like to learn more about that's not covered in the webinars that are already posted on the TOG website, let Tina know, and then she can talk to the presenters and say, can somebody do a presentation on X? And sometimes you can take a smaller question, but really get in depth with it. This was a huge question that we tried to answer in an hour. I think we might get more bang for our buck if you ask much more specific questions about specific things, and then we can kind of dive in and show examples of how to do things.
Yeah, absolutely. In the survey that you'll receive right after we close off, there's a section there where you can write in your ideas, but you can always email us. Thank you for that. That was a very good point. We're always open to ideas. That's how we improve our services and help you and help our practitioners, and in turn help your patients. So definitely share your ideas with us. And if you have any questions, let us know.
Thanks, guys.
Thank you so much. Have a nice day. Have a nice evening wherever you are in the world, and hope to see you online again soon.
Kia ora.
Bye.
Bye.